This is SG2 Perspectives, a conversation with SG2 experts and industry thought leaders about the biggest trends in healthcare and what we all expect that's going to mean for the future of healthcare delivery.
Unquestionably, when you think about virtual health broadly, the reality is that most organizations are being relatively thoughtful around how they structure their financial models to make the numbers work in a fee-for-service world.
Welcome to SG2 Perspectives. We are your hosts, Kelly Richard and Trevor Durin. And today is going to be fun because we have Chris Pagano, our Director of Virtual Health, and we are really going to push on him about the learning of virtual health in the early struggles, the areas of success, and what he expects for the future. Now, here's a disclaimer. Trevor and I will be playing skeptics today, like many of the physicians that we see on our client site. But as SG2, we are bullish on the prospect of virtual health. Our members continue to push us to show what the ROI is. And today we will push Chris. But we are not virtual health haters. We want it to work as both consumers and as people who care about the future of healthcare. Now, the gloves are off. Chris, I just want to start pretty bold here. 96% of large employers cover virtual health visits, but only about 8% of employees are using it. Why isn't it taking off a little more strongly than that?
Yeah, it's a totally fair point. There is a significant gap between adoption or the availability of these technologies among employers and the utilization rates. And so there's a number of reasons why this is the case, but to me at least, it really comes down to it being a matter of design. The way that a lot of these platforms are designed are not necessarily intuitive. You unfortunately are trying to design for two end users simultaneously. You're designing for patients who are utilizing the technology within their homes or their communities or wherever they are, and you're designing for physicians on the back end as well, right? Really, really challenging. But the bottom line is for a lot of individuals, they actually try to use the technology and they struggle with it. When you think about who is most likely to use this technology or be interested in this, of course, you automatically think of millennials, right? It's technology and they're technology natives and whatnot. But the interesting thing is when you look at the numbers around who clicks on the marketing of this, it's actually overwhelmingly 65 plus. And the reason is because that's who's actually interacting with the healthcare system the most. That's who needs the most care. The problem is that's also who has the highest attrition rates, right? So they go in, they try to download the technology. Now they have to set up a profile. They may have to download an app. It may or may not be compatible with their smartphone or with their device. They're not equipped to navigate all of that. And very quickly they'll say,
it's your mom dealing with technology.
That's right, right? And that's exactly right. And it's saying, you know what? I'm just going to call the doctor. I'm just going to go and forget it. So the reality is this. The uptake, the utilization rates will go up when these are designed in a much more intuitive way. And I'd make the case that the onus is on both the vendors, of course, who need to design these technologies in a more consumer-centric way, as well as, frankly, health systems and hospitals who have a vested interest to utilize these technologies, have them work well. They need to be working with these vendors to ensure that these are set up in a way that are actually going to serve the patients wherever they are.
Yeah. And when we're thinking about sort of that Medicare population, they're also, in many cases, going to be the most costly population. If we're looking at, the percentage of them that are chronically ill. And we're also seeing a world where payers and providers are starting to merge a little bit here. Yeah. So our question is sort of why then, with payers that are sort of on the hook for this entire cost of care, why wouldn't they buy a virtual health provider or start a virtual health provider and incentivize patients to get most of their care in the virtual setting?
Sure.
We haven't really seen that yet, but that seems to be it seems like that would make sense. But is there a reason why that's not happening?
So we have seen it. We've seen it across a number of payers, both public and private, right? So it's actually created some challenging dynamics in a number of markets where you do have a number of payers who have partnered with vendors such as American Well, Teladoc, MDLive, right? These more direct-to-consumer oriented organizations, and have essentially started offering that as part of their plans. And what's interesting is that not only are they offering it, but for some conditions, they're actually mandating that a patient needs to go through the virtual health channel first before they'll reimburse for the in-person visit. You can imagine how much hospitals and health systems like that, right? Especially if they're not offering the virtual health services. And so this has actually created some challenging dynamics where you have health systems and hospitals who are contracted with a payer. The payer is contracted with a virtual health vendor. They're channeling volume, low acuity volume, to the virtual health vendor. and it's actually eating out of the volumes within the hospital and health system. There have been some discussions around, is this conflict of interest? Is this okay? So we've seen that already occurring. And actually, we've seen situations where the hospital and health system is also using the same vendor. So the vendor is kind of playing both sides. The other area where we've seen a payer who's actually been pretty vocal about their belief in virtual health has been CMS, actually, right? So broadly, they have been pretty public in stating they've identified that they believe virtual health services can actually be a way to deliver high quality, convenient access to care and be able to bend the cost curve down. A lot of that is oriented around chronic care patient populations, remote patient monitoring, but they're expanding that this year, right? There's new CPT codes for e-visits, which are both synchronous video visits as well as asynchronous interactions for lower acuity care. And they've been pretty forward thinking in terms of introducing new reimbursement pathways across the full picture of virtual health and removing a lot of the restrictive policies that they've historically had in place. So I actually do think that we're moving forward there.
But what we haven't seen is one of the traditional commercial payers having like a $19 copay, really clear, back of the insurance card to drive volumes that way, right? We kind of see Kaiser do it, and it just makes sense that they would.
Yeah.
Why doesn't United do it? They're on the hook. They have risk.
Right.
I think it's because they really haven't seen proof that it's going to reduce any other utilization. What do you think?
It's a good question. So you're right. We haven't seen it advertised that extensively the way that you're describing, right? It's been more trying to incentivize and to try to steer individuals within the plan. I think to some degree that it probably is perhaps what you're saying, which is they're not convinced it's going to necessarily lower overall utilization, that they think it may just increase utilization, which is part of the reason that they have that back end part of it where they're saying, we won't reimburse for the in-person visit unless you do the virtual visit first, right? And so now you're basically shifting that pain point out to the patient. Let's face it, right? The health system is going to do the visit, and then when they don't get reimbursement, they're going to bill the patient. That might be kind of the other way that they're trying to get at that. But I think in the long run, you are going to see a lot more kind of bold advertising around this space, especially as they start to really figure out the incentive structure. So you're right, we haven't seen that yet, but it's early days. I suspect we will soon.
Mm-hmm. The other thing to keep in mind too is in a value-based world, if we're not looking strictly at fee-for-service and we're trying to get patients in for more preventive care to reduce costs down the line, this could be a great option for that. I think the problem is, though, we have very little revenue in risk. We're looking at 5% or less in most health systems, so it could be early days.
Unquestionably, when you think about virtual health broadly, the reality is that most organizations are being relatively thoughtful around how they structure their financial models to make the numbers work in a fee-for-service world. But to your point, I actually look at this as this is all foundational activity that as we shift to value more, and hopefully when we shift to value kind of completely, we'll get to a point where this is really going to take off, because then you have a lot of the financial incentives aligning much more closely.
Yeah, I feel like the economics, like it's easy to make the connection from a payer perspective, right? But help me make the connection from a provider perspective. Like, who is making the math work to reimburse their providers so that providers in the system say like, ooh, yeah, I want to be a part of this. I want to be on board. We know there's physician champions, but I don't think reimbursement's really the driver in many cases. Who's making the math work? And your answer cannot be Kaiser, Geisinger, or Intermountain.
Yeah, fair enough. All organizations are doing it well. I like that you took those off the board.
No layups here, Chris.
Yeah, I like that. So a few thoughts. So there's actually a number of organizations who are making the math work. The way to make the math work is to take a little bit more of simultaneously a portfolio approach as well as a programmatically individualized approach. Here's what I mean by that. For every organization that is adopting virtual health, the way they should be thinking about it is, how does this align to your broader enterprise level strategy? From there, depending on what the nature of your virtual health program is, you're going to need to design your financial program and your business model to be oriented specifically around who's staffing that, what the goals are, and what type of program it is. So your business model for example, a remote patient monitoring program is going to be very different than your business model for a telestroke program. It's going to be very different from a direct-to-consumer program. So you have to model each of these programs out individually and be able to make the math work. And so that may really kind of be focused in on, how do you think through staffing? How do you attribute downstream revenue? How do you think about cost savings, right? There's all these different approaches on the programmatic level.
So you're optimizing on the program level,
yes,
looking at ROA and the program level.
But then you can also zoom out to the portfolio level. I have a remote patient monitoring program. I have a low acuity virtual urgent care clinic. I have a telestroke program, right? Those sort of that pool of three. It may be that strategically it's important for you to launch your virtual urgent care clinic, to go to market, to provide improved access, or even as a defensive strategy, right? You have a new organization who's entering into the community, who's offering this capability, and you want to make sure that you're retaining those volumes, right? Or your competitor down the street has launched it, you better launch it too. It may or may not be a huge revenue driver for you. In fact, it may even be a loss leader. So you're going to have to think about, how do we recoup those losses at the broad virtual health level? So now it may be that the cost savings that you're realizing as a result of your remote patient monitoring program, it's not just a benefit to the RPM program, it's also kind of factoring into how you think about your ROI across the whole virtual health portfolio. Some of that might be recouping some of the losses you have in other programs that are strategically valuable. You have to have those too, even if the finances don't work. So that's really the way to be thinking about the numbers. And a lot of organizations have done this. I'm not going to name a bunch of our clients who are doing it well, but I can tell you this. We are working with a number of very large organizations, both in the South, in the Midwest, in the Northeast, even out onto the West Coast, who are not just thinking about virtual health from a perspective of how do we make the financials work within our organization. They are now taking the success that they had within their organization, building upon it, and now they're bringing it to market, right? And they're looking at that as a new revenue stream and a new business offering, and they're going to be taking a much more national view. The one example of this I can give, because it's publicly available, is Cleveland Clinic, who recently partnered with American Well. They're launching a virtual capability that is building on their virtual urgent care clinic, which was oriented around low acuity care. Now they're going to be utilizing that same capability to bring specialty care nationally. And they've certainly figured out a way to make the financials work. It can be challenging, but it definitely can be done.
So are you saying they make the financials work and that providers participating make the same amount or more money as they would doing everything in person? I didn't quite hear that.
There's a difference between the financials working at the system level and the physician compensation model.
Right.
So it's a great point you're bringing up. A couple of things. One, the reimbursement landscape is improving. We have 6 states now that have payment parity in place. For those who are listening who aren't steeped in this the way that a lot of us are here, there are 40 states across the country that have coverage parity in place. What that means is that if a payer is reimbursing for a service that is delivered in an in-person setting, then they must reimburse for that same service when it's delivered through a virtual health setting. They do not necessarily have to reimburse at a one-to-one rate, though. And we've seen this be an issue across a number of different markets where New York, for example, there are payers out there who are reimbursing for virtual health services at 50% of the rate that they would if they were reimbursing for those same services in an in-person visit. That's significant. It has created challenges around physician buy-in. But we have 6 states now that have payment parity in place, mandating that you have to pay at a one-to-one rate. Hawaii, Minnesota, Delaware. And now we've also added New Mexico, Georgia, and perhaps most notably California, which is a big deal because that is such a huge population of individuals. A lot of states look to California as kind of a bellwether state to some degree in terms of informing what's the direction that they should be taking. So I'm anticipating we'll see a lot more states go down that road moving forward. So that's the reimbursement landscape. It's improving. With that said, for a lot of organizations strategically, it makes sense for them to make their physicians whole even if the reimbursement's not equal. So what I'm saying here is there are times when the physician is comped based on reimbursement at a lower rate. And for the organization, they're saying strategically, this is important enough where we're willing to make these individuals whole and take the hit at the outset because we want to make sure our incentives are aligned moving forward so that we're incentivizing that adoption and utilization of those technologies. And I think in the short term, that's probably the way to go for a lot of organizations until some of this gets sorted out and gets a little bit more solidified.
So would you say then, if we're looking for some sort of a breakthrough or a tipping point that will really drive increased adoption, do you think it's legislative? Is it payment parity? Or is it the technology improves? In your opinion, what's going to really push us over the edge?
It's a great question. The reimbursement landscape is definitely one of the biggest pieces of this. So the fact that CMS has already taken the stance that they really believe in virtual health, they're obviously highly incentivized to think about how do we bend the cost curve down and still be able to provide convenient access to high quality care. They have been very, very candid in saying they think virtual health is a big part of that. So that's kind of tipping point piece number one. Tipping point piece number two, I just mentioned, which is I think California is actually a really big step forward. I think that's going to have a significant ripple effect moving forward. And I'm hopeful, at least, that a lot of states will follow suit there. From a technology perspective, certainly the technology.
Is there a red state, blue state pattern with any of that? I was trying to think through the states you mentioned.
I've not seen
California sets the pace, but not necessarily for every state.
I haven't seen that because then you look at like New Mexico, you look at Georgia and some of those other states, that trend doesn't exactly fit. So I don't think it falls along political lines, but it's an interesting way to think about it for sure. I think the technology is certainly another big part of this. The higher quality that resolution can be in terms of the actual video feed, I think is going to certainly play a role in terms of physicians feeling comfortable that they're making the physician-patient connection, right? They're establishing that relationship and that they can deliver high quality care through that modality. So that's part one. The other part of the digital piece is the infrastructure. So right now, and I mean, you would know this as well as anybody here in terms of thinking about rural communities, there are a lot of communities where the speed of the internet is incredibly slow and unreliable. That has to be fixed, right? It's unfortunate because a lot of these communities would really be fantastic, and some of them have been early adopters for some types of virtual health, but to be able to do things like direct to consumer in a way that it's at scale, or be able to do certain types of teleconsults at scale, you really need a very robust digital infrastructure, and that is not ubiquitously present. So I think those pieces which are improving rapidly but still have some ground to cover there, I think those are the types of things that need to fall in place for this really to take off in a significant way.
From a health system perspective, what are some of the kind of health system goals, whether it's chronic care management for systems that are trying to take steps towards value, or service distribution for really geographically dispersed systems that may have come together or grown through acquisition in the last few years? Mm-hmm. What goals is virtual health making a really positive impact on health system perspective?
First and foremost, access to care, right? The reality is that for every organization that we speak to, this is the number one thing that they're thinking about, at least in terms of virtual health, is how do we leverage technology to improve access to care? We don't have enough physicians. We have to think about how we can utilize those that we have more efficiently and more effectively. And we believe that technology can certainly serve us well in that pursuit. I would say remote patient monitoring is an area where there have been a lot of wins, right? A lot of organizations have really been focused in on chronic care patient populations, highly complex individuals who unfortunately have very high readmission rates. They have been able to show definitively that those readmission rates can go down to zero at times when you are able to actually gain visibility into what's happening with these individuals on a day-to-day basis outside of traditional physical sites of care, and then provide proactive preventative care. That has definitely been an area where we've seen very tangible, significant steps forward. Certainly classically, things like telestroke have gained a lot of traction nationally for quite a while and have been able to show value in terms of things like door-to-needle times going down dramatically, being able to allow patients to remain in their local communities and still receive that level of tertiary or even quaternary care at times, or facilitating transfers and really thinking about care continuity and improving outcomes and certainly, being able to treat patients more effectively that way as well. Certainly a lot of success there. I think the areas that I'm looking at next to be able to show, hey, where is there a lot of success here, is on that more low acuity direct to consumer side, both around synchronous video. Still somewhat early days there. We spoke about it at the top, right? Utilization has been certainly trailing availability, and there's some patient education necessary there. The other area though is apps. There has been a huge amount of activity around mHealth apps, but the reality is right now it's really hard to hear the signal through the noise. What is actually delivering value and what is not? And I think that's going to be the next area that I'm going to be really looking at closely to see what type of impact are these actually driving.
Yeah, so one thing I've heard that syncs up with rural and growing systems is the growth of asynchronous to provide low acuity access, and then the desire to find some way to do HIPAA compliant text message communication with physicians, right? You immediately get around some of the 4G and broadband challenges that way.
Right, and it's an efficiency play, right?
100%.
A lot of times the reality is these physicians, they don't need to spend 15, 20, 30 minutes with a patient to know what's going on with them at all. They can tell within 3 or 4 minutes. The rest of it is really just kind of serving that overall patient experience and just being thorough. You can do a lot of that through the utilization of smart surveys and then apps in a way that is asynchronous, more efficient for physicians, and for a lot of patients, more convenient for them as well. So I couldn't agree more with you.
Are you finding that physicians are positive about the fact that they can be more connected, or does this kind of contribute to further burnout of physicians when, there is no time that they can't be talking to patients, or no time that they aren't expected to be talking to patients?
Totally great point. I find overwhelmingly that is the latter, unfortunately. Physician burnout is extraordinarily real. It is a real issue. And I actually would make the case that a lot of the kind of resistance to change or the lack of physician buy-in to virtual health services, a lot of people think, oh, that's just they don't want to change. There may be some of that. But actually, I think what we're really hearing is physician burnout. What we're hearing is, look, not only is this challenging for us to do, but you're asking me to learn a whole new approach, a whole new process. When do I have time to do that? I'm working a ton of hours right now seeing patients. Then I'm working even more, spending time with the EMR and whatnot, especially, depending on how that has been set up and how effective that's been within each organization. I would make the case what we're hearing there is physician burnout. I would argue that organizations who want to do this, look, you have to carve out time for these individuals. You need to give them the tools that they need to be able to make this switch, to provide them with the training that they're going to require, and really put them through what I would call kind of a physician virtual health credentialing or training program. And that's not 2 or 3 hours, right? That is ongoing to ensure that they grow comfortable with the technology and that they are really feeling confident in their ability to deliver care through that modality when those types of calls come in.
As always happens when we talk virtual health, it's like, oh my gosh, there's so many cool things going on.
Sure.
So how are health systems struggling to grab onto a couple priorities out of all that? And how is that also translating to some challenges in implementation?
Yeah, it's a good question. You're right? This comes back to the point I was making earlier. There's so much activity in the space. It is exceptionally difficult for a lot of organizations to hear the signal through the noise. So a few pieces here. The first piece is we would advise organizations that they really need to be focused in on their governance structure. For a lot of organizations, what's happening is you have apps, video platforms, remote patient monitoring capabilities entering into the system at various access points. They're going in through a service line leader. They're going in through a physician who's excited. They're going through, a member on the strategy team. There's no overarching strategy there, and there's no team that is actually owning all of these activities across the system. This creates a huge amount of problems. So that's part one. You have to have that in place. Second part is you have to have a robust intake process in place as well. How are you evaluating these technologies and these vendors in a way that is going to help you to be able to only bring in the organizations that actually are going to deliver value to the organization and be aligned with hopefully what you have developed, which is a virtual health strategy. Start there, make sure that's aligned with your enterprise level strategy. That will really help you in guiding you towards a lot of the areas that are actually going to be of value. And then you can start thinking about things like the technical piece. You want to have individuals from your IT team, individuals from your legal team, individuals from your security and compliance team involved in those discussions as well, in addition to, of course, your clinical team and your operational team and everyone else as well, to make sure that the actual platforms you're bringing in-house are going to be able to deliver value not only today, but tomorrow as well.
Great. And I would like to end on sort of a fun note. Chris, we know that you don't just cover telehealth or virtual health, but you also cover innovation within healthcare. And my question would be, if we're not just talking about teleconferencing and just doing your visits over the phone or through, some sort of a video, but how do some of the new technologies that we're hearing about, such as AI, where do they intersect with virtual health to take it to the next level and really not just transform the way that we communicate about healthcare, but how we deliver care to patients?
I actually think that a lot of the disruptive change that we're anticipating actually comes from when a lot of these technologies start to intersect, right? So I actually would make the argument that virtual health is kind of one of the foundational elements. But to your point, this becomes a discussion around data. You have massive amounts of data that, as we know already, and then if you start layering in a couple other technologies in addition to artificial intelligence, 5G for sure. And then the other one I would bring up is Internet of Things, right? All of these different smart peripherals that are out there that are producing data. How do you actually deliver data to the point of care in a way that is actually going to inform care decision making? Well, the first piece of that is translating that data into an actionable insight and then delivering it to the right individual in an accelerated timeline. So the two technologies that do that, AI, right? That's the one that's actually synthesizing a lot of that data into something that actually is useful and can inform care decision making at the point of care. The second would be 5G, right? When we think about 5G, what does that mean?
No idea.
That discussion we were having earlier about digital infrastructure and high-speed internet access, right? This fixes that. once this is actually set up across the country in a way that is ubiquitous from a network perspective, this actually will deliver incredibly high speed. So for some perspective, what we're talking about here is with 4G, in order to download a high definition movie that takes about 2.5 hours, something like that. With 5G, you're talking about less than 30 seconds. Right? So we are talking about exponential acceleration of speed. Now translate that into moving data around the healthcare system, large pieces of data at an incredibly high speed. That allows for unbelievable steps forward. And certainly one of the areas that's going to benefit from that is virtual health. So I can see a future here where we have a practitioner who is actually doing a synchronous video visit with an individual. And on the back end, what they're seeing is additional insights, additional data that is going to inform their decision-making about that individual coming in from artificial intelligence in real time that's pulling from all these different IoT data sources and is able to do this in a timely fashion and actually allow that accelerated data through 5G to get to that individual during the visit. And in real time, the patient's not going to know, well, how did you know that I have XYZ other issues going on? But they know because on the back end, all this technology is happening, right? And so that's kind of where I see this kind of going in the end.
That's great. And I think that also answers the question of sort of looking at the frustration of physicians and burnout. If you have the right technology that's actually helping them provide care and making that easier for them versus being something that they just have to learn and document, I think that's great. Well, thank you, Chris, so much for coming on and chatting to us about virtual care and letting us poke some holes in your theories a little bit here. I think that we've learned that virtual health is coming. It's probably here to stay. We'll see. Hopefully we can just start having physicians get paid for it and patients learn to use it in a way that helps them become healthier.
Absolutely. My pleasure.
Thanks, Chris.
Thanks so much for joining us today for this episode of SG2 Perspectives, where SG2 experts and industry thought leaders explore the drivers of tomorrow's healthcare strategies to inform today's decision makers. Contact us anytime by sending an email to sg2perspectives@sg2.com. SG2 revolutionized demand forecasting with the Impact of Change forecast in 2001, and today we're the healthcare industry's premier strategy advisory firm. To learn more, visit sg2.com. Thanks for tuning in. Hope to see you again soon.